53-year-old man with type 2 diabetes who's admitted for acute hypoxic respiratory failure from COVID. Dexamethasone is started. His respiratory status improves, but his blood sugars range between 300 and 400 after starting dexamethasone. Which of the following is the best course of action? So do you start weight-based insulin glargine? Do you start sliding scale insulin aspart? Do you start weight-based NPH insulin? Who even knows what that is anymore? Or do you continue to monitor? Our favorite phrase. I'm going to give you 30 seconds to think about and commit to an answer. Okay, so the answer is start weight-based insulin glargine, and we will discuss why, or you can call endo. But how many of us have been in this boat? It's such a common issue. So just as a quick refresher, steroids are not harmless drugs. They have a lot of side effects. They can cause fluid retention. They can cause mood changes from like psychosis to irritability to insomnia. They can cause blurry vision, immune modulation, which is the one that we always think about. And then lastly, of course, hyperglycemia. So steroid-induced hyperglycemia actually has a definition, and its definition is exactly the same as the definition of diabetes. So to have steroid-induced hyperglycemia, you have to meet one of the same criteria we use to diagnose type 2 diabetes. So a fasting glucose at this cutoff, a random glucose above or equal to 200. And then this A1C, I didn't think of as much because usually we're just doing short courses of steroids in the hospital, but you will have patients on long-term steroids, for instance, immunosuppression with transplant organs, in which case this will come into play. So not everybody is at risk, but those who are at risk are if you're at a higher dose of steroids, so 20 milligrams of prednisolone or its equivalent is kind of the cutoff. And then of course the risk factors like known diabetes or pre-diabetes. And it's also important to know that this problem can exist after you've stopped steroids. So let's say you do that 5-day course of prednisone, even if you stopped, you can still have this hyperglycemia that lingers on. So how are we supposed to treat it? It's a temporary problem. It's something that we caused. So the way to recognize it in the hospital is if you're checking random glucoses and they're repeatedly greater than or equal to 200, then you should worry about this. You're going to want to match the duration of action of your glucocorticoid to the type of insulin, which we'll go over in the next slide. And then you're going to choose a weight-based dose. You might lower the dose depending on if your patient has a reduced eGFR or advanced age. So let's talk about that duration of action. So this is a wonderful figure from the article at the bottom of this slide, which is where all of this comes from. Essentially, we have short-acting steroids, so things like hydrocortisone, which will act on the hours, on the order of hours, and actually by hour 6 should be out of your system. So your glucose will rise and then fall. Intermediate-acting steroids like prednisone, prednisolone, or methylpred, which we commonly use, will be on the order of 12 to 16 hours, and during that time, they'll peak and then come down. And then dexamethasone is considered a long-acting steroid. So its action is variable, but it should stay in the system for about 24 to 36 hours. So that all goes to show that you should try to match your insulin type to this duration of action. So just as a refresher, for your insulin types, you have your rapid-acting and short-acting insulin. So that's things like aspart, which is what our sliding scale is, or regular insulin. These are the ones you will want to use for a short-acting glucocorticoid. And then for your intermediate-acting glucocorticoids, NPH is your insulin type of choice. And then for the long-acting, like dexamethasone, it's glargine or detamir if you so choose. So in summary, steroid-induced hyperglycemia, not everybody gets it, but if you do have it, the definition is the same as that for regular type 2 diabetes. I think the most useful piece here for us in the hospital is checking a random glucose and finding it greater than or equal to 200. And then here's a nice chart of the duration of action of each type of steroid, and then their preferred insulin type based on that. And just note that not every patient who has hyperglycemia with steroids will need insulin. there's some nuance to this, and you might actually choose a oral agent or a insulin secretagogue, but it's a little more complicated. But if you were to choose insulin, these would be your options here, ideally. And then just as a summary, you're going to look for glucose levels greater than or equal to 200 on repeat occasions in the hospital. You want to match the duration of action of your steroid to the insulin type. And then lastly, dose the insulin by weight base, and then lower the dose if they have a reduced eGFR or age greater than 70. And I didn't get into the weight-based dosing. For that, you can actually go to this article, and they have a really nice algorithm for where to start and when to reduce the dose. Thoughts or questions?